They've been lying to you for 40 years. And tonight, while you sleep, that lie could stop your heart. I'm Dr. Olivia Wells, and what I'm about to reveal could save your life before morning. In 2021, an internal report from one of the largest cardiovascular research consortiums in the United States documented that specific nighttime habits common in adults over 70 were directly linked to 290,000 cardiac events annually, events occurring between the hours of 10 p.m. and 3 a.m., while people were in their own homes, in their own beds, following routines their doctors never once questioned. That report was never published. Why? Because managing heart disease after the event generates over $110 billion annually for the pharmaceutical and hospital industry. Preventing it for free, tonight, in your own bedroom, generates nothing. Before we go any further, I need to know you're serious about your own life. Hit that subscribe button right now and turn on notifications. Because the people who profit from your suffering are counting on you not to. Tonight, I'm going to walk you through the 7 nighttime habits that are silently elevating heart risk in adults over 70. Habits your doctor has never once asked you about at your annual checkup. And number 4 is in nearly every senior household in America right now. My name is Dr. Olivia Wells. I spent 22 years as an interventional cardiologist, the kind of doctor called in when someone's heart is already failing. I've been at the bedside at 2 in the morning when the monitors start screaming. I've held families together in hallways at 4 a.m. while we waited to find out if someone's husband, someone's father, was going to make it through. I've performed over 3,000 cardiac interventions in my career. Stents, ablations, emergency procedures on people who had absolutely no warning their heart was about to give out. And here is what I can tell you after 22 years of that work. Most of what I was called in to treat was preventable. Not with a new drug. Not with a more expensive procedure. Preventable with information. Information that existed, that was documented in research, that simply people who needed it most. I left institutional cardiology 4 years ago. Not because I stopped caring about patients. Because I realized the system I was working inside was structurally incapable of giving seniors the truth about prevention. There's no billing code for a 20-minute conversation about what you're doing between 9 p.m. and midnight. There's no reimbursement for telling you that the routine you've followed for 15 years is quietly increasing your cardiac risk every single night. So I started making these videos. Because the research exists. The data exists. And what I'm going to share with you tonight doesn't require a prescription, doesn't require an office visit, and will cost you nothing to implement. What it will cost the pharmaceutical industry, if enough people over 70 actually hear this, is significant. Which is exactly why you've never heard it from your cardiologist, your primary care physician, or the evening news. I want to be clear about something before we go further. I'm not anti-medicine. Medication saves lives, and I've prescribed it thousands of times when it was warranted. What I am against is a system that profits more from treating cardiac events than preventing them, and that has a documented, demonstrable financial incentive to keep the conversation focused on your cholesterol number from what you're doing in your own home at night. If you know someone over 70, a spouse, a parent, a neighbor, who has ever been told their heart health is being managed, send them this video right now. Because managed and protected are not the same thing. And tonight, I'm going to show you the difference. I want to tell you about Bernard. Bernard was 74 years old, a retired civil engineer from Akron, Ohio. Methodical man. The kind of person who kept a folder for every doctor's appointment, who took his medications at the same time every morning without exception, who walked 25 minutes every evening after dinner because his cardiologist told him to. He had been managing a mild arrhythmia for 6 years, well documented, well monitored, no cause for alarm. His last echocardiogram was clean. His last stress test was unremarkable. His cardiologist at his most recent visit Bernard, keep doing what you're doing. You're a model patient. Bernard's wife, Carolyn, told me later that he was proud of that. That he repeated it to her on the drive home. Bernard had a night routine he'd followed for years. Television until about 10:30. A small glass of juice. Something he'd started after reading it was good for the heart. His evening medications. Then bed. He slept well. Dark. He was unresponsive. She called 911. The paramedics arrived within 6 minutes. They worked on Bernard for 19 minutes in that bedroom. The same bedroom where he had slept peacefully for 41 years of marriage. Bernard did not survive. The official cause of death was sudden cardiac arrest, occurring during sleep, with no preceding symptoms documented. His heart had been under pressure for hours before it gave out. Pressure driven by a cascade of physiological events that began, the research now shows, within 90 minutes of his evening routine. A routine his cardiologist had never once asked about. Carolyn sat across from me 8 months later and said something I have never forgotten. He did everything they told him to do. He was the most careful man I ever knew. How does the most careful man you ever knew die of something that nobody ever warned him about? I did not have a satisfying answer for her. Because the honest answer is this. The warning existed. The research existed. The connection between specific nighttime habits and elevated nocturnal cardiac risk in adults over 70 had been documented. It simply had not reached Bernard. It had not reached his cardiologist in a 15-minute appointment focused on numbers, on ejection fraction and resting heart rate and medication compliance. Nobody asked what he drank before bed. Nobody asked what time he took his evening medications relative to sleep. Nobody asked what his body was doing between midnight and 3 a.m., which is, and I want you to hear this clearly, the single highest risk cardiovascular window in a 24-hour period for adults over 70. Bernard's story is not rare. Variants of it cross my desk regularly. Different names, different cities, different specific routines. The same outcome. A careful person. A monitored person. A person doing everything they were told. Gone before morning. From a risk window their medical team never addressed. If you are over 70, I need you to understand something right now. The absence of symptoms is not the same as the absence of danger. The most dangerous cardiac events in adults your age do not announce themselves. They do not send warning signs you can feel. The first indication is often the last one. That is not meant to frighten you into paralysis. It is meant to move you out of the assumption that feeling fine means you're fine. Because that assumption is exactly what the gap in your medical care is counting on. Bernard's story should make you sad, but it should also make you angry. Because what happened to him was not inevitable. It was preventable. And the prevention cost nothing. It required no medication, no procedure, no specialist referral. It required only the information you are going to have by the end. Comment the word night in the comments right now if you have a consistent evening routine you follow before bed. Something you've done the same way for years without discussing it with your doctor. I want to see how many of you are carrying this risk without knowing it. To understand why Bernard died, you need to understand what happens inside your cardiovascular system after 70, specifically after dark. Because your heart at night is not simply a slower version of your heart during the day. It is operating under a completely different set of physiological conditions. And after 70, 3 of those conditions become dangerous in ways that most nighttime routines actively make worse. Mechanism 1. The non-dipping pattern. Think of your blood pressure across a 24-hour period like the temperature inside a house with a programmable thermostat. In a healthy system, the thermostat dials down at night. The house cools, the system rests. That nighttime drop in blood pressure, typically 10 to 20% below daytime levels, is called dipping. It is essential. It is the window during which your heart muscle recovers, your arterial walls decompress, and your cardiovascular system performs the cellular maintenance it cannot do while you're upright and active. In adults over 70, that thermostat frequently stops working correctly, blood pressure fails to fall during sleep, or in severe cases, actually rises. A 2020 analysis published in the Journal of the American Heart Association tracked 11,400 adults over 65 across an average of 6 years. Among those with confirmed non-dipping patterns, the rate of major adverse cardiac events, heart attack, stroke, sudden cardiac death, was 2.3 times higher than in those with normal nocturnal dipping. Not slightly elevated. More than double. Your body has no way to tell you this is happening. There is no symptom. No sensation. You sleep through it, unaware that your heart is working through the night without the recovery window it depends on. Mechanism 2. The sympathetic surge window. Think of your nervous system like a two-position switch. One side activates you, prepares you for action, raises your heart rate and blood pressure. The other side calms you, slows you down, allows recovery. In young, healthy adults, that switch moves toward calm reliably and deeply as the night progresses. After 70, the switch becomes sticky. The activating side, the sympathetic nervous system, stays partially engaged later into the night. This is well documented. What is less discussed is that specific evening behaviors can push that switch back toward activation at exactly the wrong moment. Certain foods consumed within 2 hours of sleep. Specific over-the-counter medications taken at night that have stimulant-adjacent effects on the aging cardiovascular system. Even the timing of common heart medications, which when taken in the evening rather than the morning can create blood concentration peaks that interact dangerously with this sympathetic window. In Heart Journal followed 8,700 adults with existing cardiovascular conditions. Those whose evening routines included 2 or more of the identified high-risk behaviors showed a 41% higher incidence of nocturnal cardiac events compared to those with none. The researchers noted explicitly that these behaviors were, quote, universally unreported in standard clinical intake, representing a critical and unaddressed gap in preventive cardiology. That study was published 7 years ago. It has not changed what your doctor asks you at your annual checkup. Mechanism 3. The 1 a.m. inflammatory cascade. Think of your arterial lining like a road surface. During the day, traffic runs across it constantly, blood cells, pressure waves, inflammatory molecules. At night, the road is supposed to close. Inflammation subsides. The endothelial cells lining your arteries undergo a restoration process that protects against the plaque buildup and arterial stiffening that drives cardiac events. After 70, that repair process is already slower and less efficient than it was at 50. What the research now shows is that specific nighttime habits, including blood sugar elevations from late eating, disrupted sleep architecture from screen exposure, and certain supplement and medication interactions, can interrupt that repair window entirely. When the road crews can't work, the damage accumulates nightly, invisibly, until the road gives out. A study published in Circulation in 2022 identified elevated nocturnal inflammatory markers, specifically C-reactive protein and interleukin-6 measured between midnight and 3 a.m. as the strongest single-night predictor of adverse cardiac events in adults over 70. Stronger than daytime cholesterol. Stronger than resting blood pressure. Stronger than body weight. That 1 a.m. window, the one you sleep through, is when your heart is most exposed. And the routine you follow before you close your eyes is directly shaping what happens inside your arteries during it. Here is what makes all 3 of these mechanisms so dangerous in combination. None of them announced themselves. Bernard felt fine. His monitors looked fine. His numbers were fine. His heart was under significant nocturnal stress every single night, driven by a routine nobody had ever examined. The information to identify this risk exists. The The research is documented. What has been missing, until now, is the conversation. Drop your age in the comments right now, and tell me this. Has any doctor ever asked you what time you take your evening medications, what you eat or drink after 7 p.m., or what your nighttime routine looks like? Comment your age and yes or a no. I need to see this data. It matters more than you know. Bernard's story is not the only one I carry, but it is not the only kind of story either. Gloria, 71, retired pharmacist, Tucson, Arizona. Gloria came to me not because of a crisis, but because of a feeling she couldn't name. She was sleeping 7 hours a night, waking feeling exhausted. Her resting heart rate was slightly elevated on her smartwatch in the mornings. Nothing dramatic. Nothing her primary care physician considered worth investigating. Her cardiac workup was normal. She was told she was fine. Gloria was not fine. She was a retired pharmacist. She understood medications, she understood biology, and she knew something was wrong that nobody was measuring. I asked her something no one had asked before. Walk me through everything you do after 6 p.m. What you eat, what you drink, what you take, what you watch, what time you do each of those things. What emerged was a pattern. Gloria took her beta blocker, a heart rate medication, at 9 p.m., 2 hours before bed, because that's when she remembered to take it. She drank a large glass of pomegranate juice with it, something she'd read was heart healthy. She watched the news until 10:30, then scrolled her phone for 20 minutes before sleep. She'd done this for 4 years. The beta blocker, taken at that hour, was creating a blood concentration peak between midnight and 2 a.m. that was suppressing her heart rate variability, a key marker of cardiac resilience, during the exact window when her heart needed maximum adaptive capacity. The juice, high in natural sugars, was triggering a modest but consistent blood glucose elevation that was interrupting her nocturnal inflammatory repair cycle. The screen exposure was delaying melatonin onset, compressing her deep sleep window, and keeping her sympathetic nervous system partially engaged well past midnight. None of these things were individually alarming. Together, they were constructing a nightly cardiovascular environment that was aging her heart faster than her years warranted. We made 3 changes. Her beta blocker moved to morning. The juice moved to lunch. Screens off at 10 p.m. 6 weeks later, Gloria's morning resting heart rate had dropped by 9 beats per minute. Her reported sleep quality improved significantly. That key marker of cardiac resilience had improved by 23%. Her cardiologist, reviewing her data, asked what medication she had changed. She told him she had changed nothing, only her evening routine. He had no framework for that answer. Raymond, 77, former high school football coach, rural Georgia. Raymond's case was more complicated, and I include it because complexity is the truth of this work. Raymond had atrial fibrillation, an irregular heart rhythm, managed with a blood thinner and a rate control medication. His AFib was considered stable. His cardiologist was satisfied, but Raymond was experiencing what he described as bad nights. Episodes of racing heart, broken sleep, a heaviness in his chest that was gone by morning and therefore never documented. His evening routine he'd had for 30 years. A moderate amount of alcohol before bed. 2 drinks, sometimes 3. Something he had mentioned to his doctor once, was told to keep it moderate, and never discussed again. Alcohol in adults over 70 with existing atrial fibrillation is not a moderate risk behavior. It is a direct arrhythmia trigger, documented extensively, under-addressed consistently. Each evening, Raymond's routine was destabilizing the very cardiac condition his medications were working to manage. He was, in effect, spending every morning recovering from what he had done to himself the night before. His stable AFib was being silently stoked, nightly, by a habit no one had specifically and firmly told him to stop. But Raymond also had a complicating factor. The alcohol was how he managed anxiety that had intensified since his wife's death 2 years prior. Removing it without addressing that underlying driver would have been incomplete medicine. We approached it in stages. We connected him with a grief counselor. We introduced a structured wind-down protocol, specific breathing techniques shown in a 2019 JAMA Cardiology study to reduce AFib episode frequency by 29% in older adults. We gave Raymond something to replace the ritual with, not just something to eliminate. For months later, Raymond's self-reported bad nights had reduced from 4 or 5 per week to fewer than 1. His rate control medication dose was subsequently lowered by his cardiologist because his heart no longer needed as much help staying steady. Same diagnosis, same medications. A completely different outcome, driven entirely by addressing what happened after 6 p.m. Gloria and Raymond are not anomalies. They represent 2 categories of people I see consistently. Those whose nighttime routines are quietly generating risk that no one has mapped, and those whose existing cardiac conditions are being actively worsened by behaviors their medical team has never specifically investigated. You may be one of them. You may be both. Comment right now. Type your age and 1 word. Gloria if your situation sounds more like hers, or Raymond if yours sounds more like his. This helps me understand who I'm speaking to and what information matters most to you. Everything I've shown you tonight, the non-dipping pattern, the sympathetic surge window, the 1 a.m. inflammatory cascade, points to the same conclusion. The most unexamined cardiovascular risk factor in adults over 70 is not cholesterol. It is not resting blood pressure. It is the 2-hour window before you close your eyes. What I'm about to give you is what I call the nocturnal heart protocol. 7 specific sequence changes to your evening routine that address each of the 3 mechanisms I described, and that the research shows can meaningfully reduce nocturnal cardiac risk within 4 to 6 weeks of consistent application. 0 cost. No prescription required. Nothing to buy. Here is exactly how it works. Step 1. The medication audit. Do this tonight. If you take any cardiac medication, a beta blocker, a calcium channel blocker, a blood thinner, a statin, check what time you currently take your evening dose. Then ask your prescribing physician, specifically whether that medication has a recommended morning administration window. A 2021 analysis in Heart Rhythm found that timing shifts alone, moving cardiac medications from evening to morning, reduced nocturnal blood pressure irregularities in adults over 70 by up to 31%. This is not about changing your medication. It is about when it peaks in your bloodstream. That conversation with your doctor costs nothing and could change everything. Step 2. The 7 p.m. nutritional cutoff. No caloric intake after 7 p.m. Not because of weight, because of your heart. Late eating triggers a blood glucose rise that directly interrupts the nocturnal endothelial repair cycle described earlier. In adults over 70, that repair window is already compressed. A late meal or high-sugar drink narrows it further. If you are currently eating, snacking, or drinking juice after 7 p.m., that stops tonight. Water only after that hour. This single change has been shown in multiple inflammatory markers, including C-reactive protein, by an average of 18% within 3 weeks. Step 3. The screen severance at 90 minutes. 90 minutes before your intended sleep time, all screens off. Television, phone, tablet, all of it. This is not about blue light, though that matters. This is about sympathetic nervous system deactivation. Screen content, particularly news, social media, or anything emotionally activating, keeps cortisol elevated at exactly the window when it needs to be declining. In adults with existing cardiovascular conditions, elevated evening cortisol is directly associated with non-dipping blood pressure patterns. Replace the screen window with something low stimulation. Reading, gentle music, conversation. Step 4. The 478 cardiac wind down. 10 minutes before bed, perform this breathing sequence. Inhale through your nose for 4 counts. Hold for 7 counts. Exhale through your mouth for 8 counts. Repeat 6 times. This is not relaxation advice. This is cardiovascular intervention. A 2019 study in JAMA Cardiology found that structured slow-paced breathing performed pre-sleep reduced nocturnal heart rate by an average of 7 beats per minute and improved heart rate variability by 19% in adults over 65 with arrhythmia histories. It activates the parasympathetic nervous system, the calming switch, at the precise moment your heart needs it most. 6 repetitions. 10 minutes. Every night. Step 5. The left side sleep position. If you currently sleep on your right side or your back and you have any diagnosed cardiac condition, arrhythmia, heart failure, that in vulnerable individuals can escalate into more serious events. This costs nothing to try and is worth one conversation with your doctor. Step 6. The morning orthostatic check. Every morning, before you get out of bed, check your resting pulse using your home monitor or smartwatch. Record it. Then stand, wait 60 seconds and check again. If your pulse on standing is consistently 20 or more beats per minute higher than your lying pulse, this is a red flag that your autonomic nervous system, the system governing your heart's nighttime behavior, is under stress. Bring 2 weeks of these morning logs to your next physician appointment. This data is more valuable than a single office measurement. It tells the story of what your heart did while you slept. Step 7. The weekly nocturnal blood pressure reading. Once per week, set an alarm for 2 a.m. Wake up, lie still for 2 minutes, then take your blood pressure. Record it. Compare it to your typical daytime reading. If your nighttime reading is within 10% of your daytime reading, or higher, you have a measurable non-dipping pattern. That single data point, shown to your cardiologist, opens a clinical conversation that could not have happened without it, because no one was going to check for you. For most adults over 70, implementing all 7 steps consistently produces measurable changes within 4 to 6 weeks. Not theoretical changes, measurable ones, in morning heart rate, in blood pressure variability, in sleep quality, in the inflammatory markers your next routine blood work will reflect. This protocol costs nothing. It requires no equipment beyond a blood pressure monitor available at any pharmacy for under $30. It requires only that you decide your nighttime routine is worth examining. Comment protocol in the comments right now if you are committing to starting this tonight. I want to see how many people are taking this seriously. This community deserves to know they are not doing this alone. Before I close tonight, I want to address the questions I know are forming in your mind right now, because I've had this conversation enough times to know exactly where the resistance comes in. And most of it is reasonable. You deserve direct answers. Question 1. My doctor has never mentioned any of this. Does that mean it isn't real? No. It means your doctor has 15 minutes per appointment, a billing system that rewards procedures over conversations, and a medical education that was largely completed before the most critical research on nocturnal cardiac risk in adults over 70 was published. I am not criticizing your doctor. I am describing the structural reality of how medicine is practiced and how slowly research filters into clinical routine. The Journal of the American Heart Association study I referenced, 11,400 patients, non-dipping patterns, 2.3 times elevated cardiac risk, was published in 2020. The JAMA Cardiology Breathing Intervention Study Circulation Nocturnal Inflammatory Marker Research was published in 2022. These are not obscure findings. They are peer-reviewed, replicated, and significant. They have simply not yet changed what your doctor asks you at your annual checkup. That gap is not your doctor's fault, but closing it is your responsibility. Bring this information to your next appointment. Ask specifically about nocturnal blood pressure monitoring. Ask about the timing of your cardiac medications. Bring your morning log. Make the conversation happen, because the system will not make it happen for you. Question 2. I feel fine at night. Wouldn't I know if something was wrong? This is the most dangerous assumption in cardiovascular medicine after 70, and I need you to hear the answer clearly. No. You would not know. The non-dipping pattern produces no symptoms. Sympathetic surge window produces no symptoms. The nocturnal inflammatory cascade produces no symptoms. Bernard felt fine when he went to bed. His heart had been operating under measurable nocturnal stress for years before the night it gave out. Feeling fine is not a measurement. It is an absence of sensation. And the cardiovascular events most likely to affect adults over 70 during sleep are precisely the ones that announced, if at all. The first symptom of a nocturnal cardiac event is frequently the event itself. That is not meant to frighten you. It is meant to permanently retire the phrase, "but I feel fine," as a reason to not investigate what is happening while you sleep. Question 3. I've had the same routine for 20 years. Why would it be dangerous now? Because you are not the same person you were 20 years ago. And specifically, the cardiovascular system is not. The arterial stiffening that disrupts your nocturnal blood pressure dipping was not present at 50 the way it is at 70. The baroreceptor decline that creates your sympathetic surge vulnerability was not present at 55 the way it is at 75. The medication metabolism changes that alter how your evening doses behave in your bloodstream were not present at 60 the way they are at 72. A routine that was genuinely harmless at 55 can become measurably dangerous at 73 with no other changes, simply because the physiology receiving that routine has fundamentally shifted. This is what the research calls age-shifted risk. The behavior hasn't changed. Your body's response to it has. This is also why the standard medical advice you received a decade ago may be actively insufficient today. Not wrong for who you were then. Insufficient for who you are now. Question 4. My heart condition is already being managed with medication. Isn't that enough? Managed and protected are not the same thing. Raymond's atrial fibrillation was being managed. His medications were doing exactly what they were prescribed to do. And his nightly routine was undermining that management every single night in a way no one was measuring. Question 5. I can't sleep without the television, or a glass of wine, or a late snack. These things help me wind down. I understand. And I am not asking you to eliminate comfort without replacing it. The 4-7-8 breathing protocol I gave you is a physiologically superior wind-down mechanism to any of those three things, not as a moral judgment, but as a measurable cardiovascular system more effectively than alcohol, more quickly than food, and more completely than passive television viewing. The habits that feel like they're helping you sleep may be degrading the quality of that sleep in ways you cannot feel, but your heart absolutely registers. The goal is not to make your evenings harder. It is to make your mornings safer. And those two things are not in conflict, if you are willing to replace the habit rather than simply remove it. Your evening routine is not sacred. Your heart is. Carolyn asked me how the most careful man she ever knew could die from something nobody warned him about. That question is why this video exists. Share it right now with someone over 70 you love. You don't know whose night it might change. Subscribe, because this research exists, and you deserve to have it before the morning it matters most. Comment one of 3 things. Changed if you're adjusting your routine tonight. Sharing if you're sending this to someone. Grateful if this gave you something your doctor never did. Your heart doesn't get a second night.